Hello, everyone. My name is Gio Nogales, and I am a paralegal here at Lyles Parker. Thank you for joining us for this new webinar series with the Home Care Association of Louisiana. To get us started today, we have Dr. Warren Hebert. So Dr. Warren Hebert made his first home health nursing visit in 1985 and has been the CEO of the Home Care Association of Louisiana since 1998. An assistant professor of nursing for 4 years at Loyola School of Nursing in New Orleans. Warren is now adjunct there and at the Rutgers Institute for Healthcare Policy and Aging Research. Dr. Hebert is on the expert panel on aging of the American Academy of Nursing. Take it away, Mr. Warren.
Thank you, Gio, and welcome everyone. We're very excited to be partnering with Lyles Parker for this webinar series. This will be our 5th, and we are happy to be getting as much information as we can to those of you who are out across the country, and particularly our members here in Louisiana. So thank you, Robert, and today Paul as well for the presentation you're going to do. Risks facing your agency if you hire a contract, an individual or entity on the OIG Exclusion List or CMS Preclusion List. So we really appreciate this. I always start with a bit of a story and information. One of the things that we know very well and we don't think about a lot in our day-to-day work because we're focused on the competencies of care, we're focused on regulations, we're focused on aspects of reimbursement. But one of the important things that's been studied for about a decade or so is loneliness and social isolation among people that are aging. The research shows that loneliness and social isolation impacts an individual's morbidity and mortality more than smoking a pack of cigarettes a day or drinking a half a dozen adult beverages every day. So those of you who are out making visits and those of you listening who are supporting visits know that your engagement with the people we see across the country in doing home health care is critical to their well-being, not only from a standpoint of the medical things you're doing, but just your opportunity to engage them and help them to connect with others. So thanks again to Lyles Parker. We appreciate your good work. Robert and Paul, thank you for today's presentation.
Thank you so much, Mr. Hebert. So like he said, today's webinar is entitled Risks Facing Your Agency If You Hire or Contract with an Individual or Entity of the OIG Exclusion List or the CMS Preclusion List. Our presenters for today is Robert Lyles and Paul Wainfeld. Robert has worked on the healthcare provider side as a federal prosecutor and now defends home health, hospice, and other healthcare providers around the country in Medicare, Medicaid, private payer audits, and False Claim Act cases. While working as a federal prosecutor, Robert was asked to serve as the country's first national healthcare fraud coordinator for the Executive Office for the U.S. Attorneys. In this capacity, he advised federal prosecutors around the country regarding healthcare fraud statutes, schemes, investigative tools, privacy concerns, and compliance issues. And as for Paul, a Louisiana lawyer with expertise in healthcare litigations. After several years of service as an assistant U.S. attorney in New Orleans with responsibility for the healthcare fraud docket, Paul moved to the Washington area to serve as a national healthcare fraud coordinator for the Department of Justice. Since leaving the DOJ, Paul's primary focus has been the defense of providers in the healthcare matters. Paul also has an extensive litigation background. It includes over 50 trials and appeals and arguments before the United States Supreme Court and the Louisiana Supreme Court. In 2014, Paul co-founded Exclusion Screening, LLC, in order to help healthcare providers navigate the difficulties and issues related to the screening for excluded individuals and entities in all of the federal states exclusion registries. This is just a quick reminder If you have any questions throughout the presentation, please feel free to type them in the chat box, and we will address them as many as possible at the end of the presentation. Without any further ado, I present to you your speakers, Robert Lyles and Paul Wingfield.
Thank you very much, Gio. Dr. Hebert, it's always a pleasure. We appreciate our partnership with the Home Care Association of Louisiana. And I'm really glad to make this presentation today with my old friend, Paul Weidenfeld. Paul's coming to us today from Washington. Dr. Hebert is down in Louisiana, and I'm in Florida this week. So it's, you know, we're all over the place, but this is an interesting issue, and it's something that a lot of the folks that are on the line have probably not given much thought to. This is the single least appreciated risk issue facing healthcare providers, including home care, personal care, home health, hospice agencies. It's really something you have to worry about, and we're going to get in today and kind of explain what this risk issue is. Paul, good to be on the line with you again.
Well, Robert, thank you for inviting me and for having me. I wanted to say one thing. When you say your old friend, I really didn't quite appreciate that. But, you know, we're not supposed to focus on that sort of thing, are we?
You're right. Okay, Gio, next slide. Okay, this is just an outline of what we're going to be covering today. We're going to cover not just aspects of exclusion screening, but also talk about this relatively new, it's not really new, but it's only a few years old, this new area that you need to be worried about, and that is preclusion and the inappropriate engagement or hiring of someone who is on the CMS Preclusion List. But we'll go over all of these things. Next slide. Now, Paul, you are truly one of the nation's experts on exclusions. So I'm going to turn this over to you to kind of explain what is an exclusion.
All right. So an exclusion, it means it's a final administrative action. It's an action taken by, it can be by the state. You can exclude someone from your state, or by the feds. Typically, we're thinking of Medicare and Medicaid, Medicare exclusion, federal exclusion. They're administrative actions, but once imposed, they bar all participation in federal or state healthcare benefit programs. So once you're excluded, it is presumed that you are a risk to the two most important areas of a healthcare program, which are patient safety, number one, and the financial integrity of that program. States and feds have parallel, or they're each their own independent authorities and mechanisms to impose these things. Is that about? I think that pretty much covers it.
Next slide, Gio. So exclusions are something that has been around a long time. I mean, it goes all the way back to the 70s. So this is an issue that it's long-standing, but it's also one that is probably the least appreciated by healthcare providers. And
it's interesting.
Yeah.
I'm sorry. It is interesting. Your slide here. It goes back all the way. You know, that's what, 50 years, 1977. And the idea has been to keep a certain type of person out of the program. We don't want, you know, and they were trying to define that, but we don't want people who pose these risks involved in healthcare. It's a basic idea.
Next slide. So what is, and you know, you said it was a final administrative action. But based on what? Why do they take these administrative actions that effectively exclude someone from being able to participate? What's all that about, Paul?
So there are, as you can say, mandatory versus permissive, which is, there are two types of exclusions, but the impact is pretty much the same. It's just how you arrive at that circumstance and the length of it. So a mandatory exclusion means that if you've done, this is under the Social Security Act, and under these four bases, if you've done one of these things, you're convicted of a delivery of an item or service to a healthcare program, state or federal, if you've been convicted of an abuse of neglect, if you specifically a felony relating to healthcare fraud, or some of the drug programs. If you are convicted of something that fits into one of those four categories, then the Office of Inspector General can and will exclude you. That's the basis of the exclusion. Once you've done that, it's automatic. You can't now, in the administrative process of imposing the exclusion, you can't say, well, there was the wrong, they shouldn't have gotten me. It's a done deal. You will be excluded on that basis.
Okay, next slide.
And so
these are permissive exclusions. What's the difference between a mandatory exclusion and a permissive exclusion?
In effect, not any, right? They have the same impact. But the difference is that whereas the mandatory exclusions, these are automatic if they happen. The permissive exclusions, these are, this is just a category of things that if you've done it, then they may proceed and seek your exclusion. Now, here's the thing about this. It sounds like, well, maybe yes and maybe no. But the fact of the matter is, on certain ones of these, in particular, the one that's in red, license revocations, suspensions, and surrenders, if a doctor has been or has had their license revoked or suspended, or a nurse, or anybody within the healthcare community, that can be the basis of an exclusion. And once again, you cannot argue that you shouldn't have lost your license or the underlying impact. If you've had your license lost, you will be excluded. Now, the minimum period is different, 3 to 5 years. In some of these, they could perhaps, like if you looked at 13, failure to take corrective action, that's a basis, but they don't ever really seek those. What we're really talking about on the permissive side are three things. Patient abuse that hasn't been convicted, license revocations, and as we love to say, failure to pay a federal loan. If you don't have repaid your loans, you can't get a federal job, number one. And number two, you can end up on the exclusion list.
Okay. All right. So if we have someone who has been convicted of certain crimes that qualify for a mandatory exclusion, or they have engaged in other types of conduct that would make them eligible for excluding them permissively, okay, then the OIG can decide if it's permissive whether or not to pursue one of these actions. Is that correct?
That's right. That's right. And Robert, I'm going to pass this back to you for a second, because I know you've had a lot of experience with these B1As, these misdemeanor convictions related to healthcare, or these convictions related to non-healthcare fraud programs. You know, what happens? What do they mean by conviction? What happens if we've seen a lot of cases, and I know you've represented them, in cases where it's been a no-low plea, or there's been kind of a deferred prosecution, or it's been under certain provisions where you can withdraw your conviction later on, or your plea. How does that work?
Well, it's really interesting the way they define conviction, because you would look at it, and a normal person would say a conviction. That means you've got to be convicted. But the way they define conviction under this particular statute for this particular purpose, you're right, it's very, very broad. And deferred prosecution, which is whereas you work something out with the prosecution and you agree that if you take certain steps and you keep your nose clean for a certain period, they will wipe it off your record. For purposes of exclusion, that's still considered to be a conviction. And
how is that? How can that be?
Well, because statutorily and under the regulations, that's how they defined it to include. You have to understand the whole purpose of this statute is to do two things. Number one, most importantly, protect Medicare and Medicaid beneficiaries from people that have a history of bad acts, if you will. Okay, that's number one. And number two, protect the financial integrity of the program. So when we talk about someone who's been excluded, that's a fancy way of saying if they're excluded, that means not only can they not participate in Medicare or Medicaid, but they can't work for anybody that does Medicare and Medicaid or other federal health programs either. You know, it is like the nuclear bomb. If you are excluded, and we're going to go into these in more detail, but just to kind of put it in perspective, if you're excluded under one of these mandatory or permissive provisions, you are essentially out of healthcare in terms of any provider or supplier that takes federal healthcare benefit program patients. That's just it. The most you could do would be if you're a doctor, because you have to understand, and this is something for our home care and hospice folks to keep in mind. You guys employ a lot of nurses. You can be excluded and still be properly licensed in that state. You can have a license. That individual can still work as a nurse. Not a problem with that. But if they're excluded, they can't work for you because everyone on this phone call takes Medicare and Medicaid.
You know, and that's something where it's important to understand that licensing and exclusion, as you say, are two completely separate matters. And we often see that someone that's been excluded, they're seeking to get their lives back. They resolve their licensing issues. They have their license back. They're licensed to practice as a nurse or a physician or what have you. But they still are not off. They still have to get off the exclusion list. And I think we talk about how you do that later. But it's a separate issue. It's like that 3 years passes and that's not, and that doesn't matter. You have to get back on. But something on this slide that I think is important for home care folk to understand, that 70% of the people who are have been excluded are nurses. And that's a huge percentage. And they focus on, because the focus is on two things, patient safety and on the fifth. And so I think they're really looking at, they often try and target folk who are dealing with patients, right? And the people that are dealing with patients the most are in home care settings or hospice settings or nursing home settings. And that's, you know, that's where our population is. That's who we're talking to. These are the people that are, you know, in the rooms and in the houses. And so they're looking, you know, they really are focusing on and targeting people who are in those positions. They're affecting the reimbursement because it's on their word that reimbursement continues in many ways. And they're protecting the patients because they're the ones in the houses or in the rooms or wherever.
Next slide. Okay, so one of the issues to kind of keep in mind, you say, okay, Robert, Paul, I understand, I got the message. We can't hire someone who has been excluded from participation, but how am I supposed to know who's excluded?
Right.
Paul, you want to talk about the various types of lists?
Well, let's start with the big bopper, the OIG. That's the Office of Inspector General. Those are the feds. They are authorized to impose exclusions. They by statute or by regulation or by who knows how they do those things. But anyway, they're authorized to impose the exclusion. They post the list. It's the LEIE, which stands for the List of Excluded Individuals and Entities. They update it every month. They add people every month. They add about 3,500 a year on average. They take some people off, not as many, so it grows. That's one list. Now, every state, not every state can have their own list, and most do. I think at current count, it's almost all. It's up to 44. Some state lists out. Here's where the problem is. The federal list, you can download the OIG's list. You can also manually do screens at about 5 at a time. It's a pretty unwieldy list at 75,000 people, but it's got a lot of data points in it, right, Robert? It's got dates of birth, and it's got dates of exclusion. It's got addresses, and sometimes it has NPI numbers, sometimes it has license numbers, but it's got a fair number of data points. You can figure it out. The state lists, on the other hand, are all over the map. Louisiana's list is actually pretty good. It has dates of birth. It has a number of data points. But there are some states that literally have a name, maybe an exclusion date, maybe an address, maybe a license. Some have like maybe 2 or 3 data points. They could be on Excel. They could be on a PDF. They could be in a Word document. It's almost impossible, really, for any entity to screen those lists. So the question is, are they required to? And we talk about that a good bit. Robert, why don't you talk about the preclusion list, since you know a pretty good bit about that?
Well, we're going to go over the preclusion list in some later slides, but just generally, the preclusion list is a completely separate list that is maintained by CMS. The problem with the preclusion list is no one on this phone call has access to it, which makes it really tough. The preclusion list is really used for Part C and Part D. If you're on the preclusion list, that means you're not eligible to be a participating provider or to really work for anyone that participates in Medicare and Medicaid, if you also participate in Part C or Part D. Now, we're going to talk about, why are you even telling us about it if we don't have access to it? Well, I'm telling you about it because your employees, if they're ever put on the preclusion list, they will get a letter from the government, and they're supposed to let you know that, in fact, they have been precluded. You will also hear about it, though, because these days, in many states, the Medicaid managed care program and the Medicare Advantage programs, which are, of course, Part C's, those programs will let you know, if they identify someone working for you that has been precluded, because they're not going to want to pay you. So we'll talk some more about the preclusion list in just a second, but there are other lists as well that you may want to look at, the GSA list. You want to talk about that, Paul?
Sure. The GSA, the General Services Administration, that's a debarment list, which is more of a contracting concept than an exclusion. In other words, each agency can debar someone from doing work with them for many different reasons that may have no impact on healthcare. However, managed care plans and Part C and D plans are required to screen those as well. And if you're on those lists, then you can't submit claims to Part C and D. And as we know, what's the current percentage is well over 40% and rising. It's hard to tell who's managed care, who's private, who's straight Medicare these days. And if you're on that list as well, you have to screen that list for the plans. And if you're on that list, you won't be able to participate either. There are other lists that may from time to time come up contractually. You may be asked to screen these OFAC, which is that's the alien, not the aliens from the sky list, but the other list. Anyway, that's the Treasury list. Because we can't do that other alien list yet, although we're looking. Anyway, specially designated nationals, etc. Elder abuse list. Some of you probably have to screen for state reasons to do some of these other lists. Those are different. If you have to do them, it's important that you do. But those would be contractually required lists.
Okay. Next slide. All right. So the reason why it's so important to screen is because if you don't screen and you inadvertently hire someone who has been excluded from participation in federal health benefit programs, then everything that they touch is tainted. Now, this can be a real problem if you're talking about someone who is a billing provider. That's probably not going to be the situation in home health and hospice. But everyone that you have there, not just your nurses going from home to home, but your IT people, your administrative people, the government considers all of those folks to contribute to the overall basket of services that is provided. to Medicare and Medicaid patients. And as a result, if one of those people is working for you, whether they're an employee or a contractor, either way, you will be held liable and subject to all kinds of penalties. It's also important to remember that they don't consider it to be just limited to direct employment, but also indirect. So Paul, can you give some good examples of indirect?
Sure. You know, the indirect would be anybody that's not directly providing the service. So they'll talk about, say, a surgical assistant. That's one. Here in the nursing home, anybody that's doing your billing, that's someone who's doing, anybody who is your transportation company, if you have a transportation company. You know, you don't bill individually for your office, for your visits to the home, but they're obviously, they're directly, but the indirect ones would be anybody who's providing the transportation, any service that indirectly submits the claim. And you can't make a subterfuge. You can't try and get around it by having someone who's excluded pass it over to someone who isn't excluded, and then they submit the bill. So let's say you're, just an example, let's say an orthotic, just because that's what comes to my mind here, for your shoe, the person who manufactures, who actually makes them, they're excluded. Well, they can't now sell them to you, who's not excluded, and then have you provide them and submit the claim for them. You're trying to get around the bus. You can't do it. That's indirect. That's the idea.
There was a case that recently came out last week, in fact, wasn't it, Paul, where a billing provider, I think it may have been a podiatrist, was using another individual, another physician, to provide the services, who was excluded. And then they were billing those services under the number of the physician who was not excluded. And they ended up going after those guys criminally.
Well, there's a case in New Orleans, actually, in Louisiana, where a doctor who was excluded, he became a biller, and he thought that he could submit claims because that would be okay. The Supreme Court considered it and said, no, you are indirectly submitting claims, and that would be, and that's inappropriate, and that could be, they allowed the case to go forward. I'm not sure what the result was. And another case in Louisiana where an excluded doctor was providing services, and they billed the services under someone who was not excluded. Can't do that either. And that guy went to jail. Went to jail for that.
Yeah, and we're going to talk, Louisiana has some very specific requirements when it comes to screening. So we're going to talk about those coming up. Next slide. Okay, we talked about direct versus indirect. We talked about employees. What about vendors and contractors and volunteers? What's all that about? We're talking about now in the context of home health and hospice.
So we're going to talk about screening in a couple of slides, but the idea is anybody that, you have to ensure the status of anyone doing business with you, and that's providing a service that's going to ultimately be billed. So if you've got a vendor or a contractor that you're doing business with them, their business ultimately results in the submission of a claim. You can't do that. So the basket of services, the best example is volunteers. The OIG, specifically in guidance issued back about 10 years ago, actually said, look, even a volunteer, if that volunteer is providing a service that is part of the basket of services you're required to provide. For example, if you're in a nursing home and your volunteer is cleaning the rooms because they like to clean the rooms or cleaning the premises or doing anything that's part of your obligation, they can't be excluded. Now, I haven't seen any volunteer cases, but that's what they say.
No, but I could see in the home health and hospice context, I could see situations where they have an opportunity to provide training to students and other individuals And those students that would work in those types of training programs, whether it's a mentoring program or whatever it is, you've got to screen them because they would be just like a volunteer. And the vendors and contractors, staffing agencies, home health agencies regularly have to rely on staffing agencies to fill in holes or gaps in staffing when they have somebody. You have to be really careful because we've seen situations where the staffing agency, they're supposed to be doing the screening, they're not, okay? And I've actually seen a case where a staffing agency sent someone around to half a dozen organizations over a period of time to do work, and it turned out that that individual was excluded. And every one of those organizations had to pay back a lot of money, okay? So when it comes to staffing agencies, I would not let anybody work for me, okay, unless you do your own screening. Be very, very careful.
Agreed.
Next slide. Okay. Now, we're talking here about really, it says with the practice, but really it's with the agency. What we're really getting to there is, it's what Paul said earlier. It's not just the folks that have hands-on care with patients, okay? It's everyone that contributes to that overall basket of services, from your administrator to your billing people, even your receptionist. Okay, all of these folks provide certain services, and together all of these services constitute your home health or hospice agency, our personal care agency. And you have to understand that you have to screen all of those people. And I will tell you, it covers all federal payers, not just Medicare and Medicaid, but FEHBP, railroad retirement, TRICARE. So, if you're thinking, well, we just happen to live near a military base and we have a lot of retired military here, all federal plans are covered under this exclusion prohibition. And Paul, what is your experience with the private payers these days?
Well, so the thing about the private payers is, one, it's hard to distinguish with the private payers these days, with them taking so much of, they also do Medicaid. A lot of times if you go to a private payer site, it says, do you want a Medicaid? Do you want part managed care, that Medicare? Do you want Medicaid? Do you want just a private? And so it's hard to tell. And so because they've been so involved, it's been, what I've seen is they're so involved now with Part C, Medicare, and, with managed care and with Medicaid, which do not allow, obviously, that have the payment prohibition. Their private provider agreements all basically contractually are requiring the same thing. And they're saying, we're not going to pay either. I mean, if the feds aren't going to pay, why should we? Which makes sense, frankly. So it's really extended. Now, and I think that there's a strong, historically, private pay has followed, their private units have followed federal action, and I think that's exactly what will happen in some of these exclusion matters.
And ultimately, Paul, don't you think that this is, we really want to get across this message that this is not a check the box. There is a real purpose here, and that is to protect your patients. And the private payers are saying, well, if Medicare and Medicaid don't want these bad actors near their patients, why would we?
And you raised such an important point, Robert, because all of the risk that you have, and when I say you, I mean people listening to this, home care providers, hospice providers, the risks are not, they're not tornadoes particularly. They're in your people. They're in your employees. The risks of harm to patients, the financial risks that you might, they're the ones that are most likely. That's where your risks are, in your people. The things that happen, clinical mistakes, errors, what have you, malpractice, everything comes down in healthcare to people. And the way to protect yourself is to have good staff. I don't need to tell people this. This is obvious. Well, it's also one of the things you want to do is make sure you don't have people that are going automatically. They are a risk if they're your employee. They're a risk to the program because the program doesn't want them. They are presumed to be a risk to you and to your patients. So it's just an idea that it just makes sense. If they're on that list, any of these lists, and we're going to talk about that, how you find that out, you got it. You don't want them on your. They may be nice people. They may be better, but they're there.
Yeah. Next slide. Okay. Now, Paul, this is something that I know you love to talk about. Background checks, and I actually sent around an article to everyone in our firm today about a recent background check gone bad. And you know, there are so many providers that we talk to, and we say, well, are you screening? And they say, well, we do background checks. I'm sure that covers it. Is that the same thing or not?
Well, no. I mean, even a legitimate background check probably is not going to cover it's not going to find an Iowa or a Minnesota exclusion if it isn't anywhere else. They don't have the wherewithal to go through all of those unless they hire a third-party vendor like Exclusion Screening, but they probably are not. However, so even the legitimate ones wouldn't, but there are a lot of background companies that are really, people that provide background BS. What else can you call it? I mean, fake background stuff. We can provide you with actual names of companies that say, all right, tell me the degrees that you want. We give you 2 or 3 phone numbers for references. What degrees do you want? What do you want to have been? Where do you want to have gone to school, et cetera, et cetera. You fill in the blanks, and we provide it for you for as little as $45, depending. The premier services will go up to a couple of hundred, I think. But it's all out of whole cloth. Now, we've seen that recently with some people running for office. But you can imagine, if they can do it running for office, you can imagine that they'll make stuff up to get a job.
Okay. All right.
Next
slide. Next slide. I know. All right. So, is it a law, Paul? Is it a law that says you must screen?
No. It's only a law that says if you don't, you can pay civil money penalties and overpayments, and you may be responsible for False Claims Act. They do it in the reverse. They say you're responsible.
It's a typical carrot and stick scenario.
It really is. They flip it around. Instead of saying you have to screen, what they say is, if you don't screen, here's all the bad things that can happen. Isn't that the same thing? I don't know.
It is. But I will say, and we're talking now about federal law, because people ask us, well, what is the federal statute that says I have to screen? Well, there's not one. But if you don't do it and you hire someone inadvertently who's excluded, you have real problems. Having said that, though, a number of states, and we're going to talk about Louisiana in just a second here, have their own very specific provisions that require screening, okay? And many private payers, as you said earlier, Paul, as part of their participation agreement, they also say you have to screen. So there are all kinds of contractual obligations that are out there. Some states have actually codified the screening requirement into the state regs. Okay, but there is no federal law. Next slide. So I think we've kind of covered this a little bit. Next slide. Okay, so what is the best practice, Paul?
Well, so let's say what screening. We keep saying screening, and what is and so people might be asking, well, what do you mean? And so what we mean is you compare your list of, you make your list of who are you hiring that's involved. That's going to be everybody. Your employees, your vendors and contractors. There'll be some vendors, some contractors that are participating with you. You make that list and you compare your list of people and entities with the various lists. Now, how do you do that? It's pretty hard, but this is On the OIG, you literally can manually enter like 4 names at a time, and then you can confirm it with Social Security numbers. But you are comparing your list with these lists. That's what we mean by screening. Now, how do you do it with 44 state lists? It really is impossible for an individual practice or an individual agency to compare your list of 50, 75, 25, whatever it is, people with those lists. But that's what they mean, and these lists are considered public notice, which means you are presumed to know their contents. So that's what this screening means. Now, what's the best practice? You are required by most states in Louisiana, and most state Medicaid, or I think all states now, say you are required to screen before you hire and monthly thereafter. That's the basics of your list. It's that simple. Monthly, when you hire them, you're making sure on the front end that they're not excluded, and then monthly thereafter. Why every month? Everybody says that seems ridiculous. Well, people get added to the list. You know, you hire them,
Paul,
and they're...
Let me ask you a question, Paul. Going back to indirect and screening a little bit. Everyone on here, the home health, the hospice folks, they get referrals, okay? They get orders from physicians who say, I want you to evaluate this patient. I want to order this patient to be admitted into home health. What if that ordering physician is excluded?
That's a really good question, because they have certainly, if they've ordered it, right, they have directly contributed to your submitting the claim. They can issue an order. There is nothing wrong if their license is intact and they have, if they are licensed within the state, they can issue the order even if they're excluded. But if you submit the claim, now you've done it based on someone that that's a bad claim. That's a tainted claim. And so you really should screen all of the doctors, all of the people that submit, that you sign your plans of care, that make referrals to you.
And we base this, or I know, Paul, you base this opinion on the fact that we've seen a number of situations where doctors that were properly licensed, they saw a Medicare patient, and the doctors were excluded, okay? They hadn't gotten off the exclusion list. They saw a Medicare patient, they issued a prescription for a med. That patient then took it down to their local pharmacy, and we're talking about the big names that you all recognize, and the pharmacy filled the script. And then later on, the government came in and said, that may have been a legitimate script, but you can't fill it because we had to pay for it. So since the referring doc was excluded, that's a bad prescription as far as we're concerned with our program, and you, pharmacy, have to pay us back, plus a lot of money in penalties. That's the problem that you've got here for home health and hospice if they don't check the referring docs. They need to check every one of them every month, because if one of those docs gets excluded, believe me, the government's going to pick up on it, and everyone that is associated with that doc and any orders issued by that doc is going to get hit.
And as we know, the way they do things, the way the feds do things is once they find, once they're latched on to somebody that's a problem, right? And if that problem person happens to be excluded, they branch out and they look at all of their relationships. They look at all the people that they were doing business with. And a lot of people can get tarred by, they think that this piece fine, they think that there's no problem, and but if they've been excluded,
he's a well-respected licensed doc. He's got a beautiful office. Everybody loves him in our community. But what you don't know is he was excluded for some odd reason that you may not know about. Something as mundane as he didn't pay back his student loan.
And the weird thing is, Robert, and as we both know, they a lot of times their lawyer didn't really explain things. They said you had a 3-year permissive exclusion because you had your license suspended. Okay, your license gets back. They think the exclusion's gone, and the lawyer didn't explain to them particularly that, hey, you got to get back in the program. It's not automatic, and that's often a problem, isn't it?
Nothing automatic about it. And you and I have seen cases where a doc should have been off the list 12, 15 years ago, didn't know he had to affirmatively go in to get off the list. And as a result, he ended up costing his organization a lot of money, because even though his exclusion theoretically expired 15 years ago, by not formally going in and petitioning to be taken off the list, he was still considered to be excluded. Next slide. I know we got a lot more here. Can they do their own screening? We've already talked about this. They really can't. There's a lot of companies out there, guys, that do screening. I, of course, as Paul and I established the company, I don't know, 10 years ago, exclusionscreening.com. That's where I recommend you look at for screening if you're not doing it already. Next slide. Okay, we're going to skip this. This is Texas. I should have taken that one off.
Yeah.
That should have been taken off too. Next slide. There we go, Louisiana. Okay, let me cover these fairly quickly, but these are all very important. These are from the Louisiana Medicaid Provider Agreement, okay? And where you see the four different bullet points there, any past or current owners, agents, managing employees, any individual owner, any past or current owners, you know, with a controlling interest, or have had or currently had any involvement with, or has the agent or managing employee named above ever. The reason I did this, there are 4 separate pages in the provider agreement, one with each one of those bullets, and then the question that I have, the yes/no question at the bottom. Been denied enrollment, suspended or terminated, excluded, or voluntarily withdrawn. Okay, ever. Okay, so Louisiana is the toughest state I know of when it comes to screening people from participation, because in the Medicare, on the Medicare side, you have to affirmatively say that you have never essentially been excluded, been an owner who was excluded, been a manager who was excluded. You know, it's just really quite broad. It's really impressive, frankly, as a former law enforcement person. I've never seen any state go this far. Have you, Paul?
No, I mean, this is like, are you now or have you ever been kind of question.
Yeah.
And maybe we find those kind of questions offensive in general, but in particular, how can you answer that for your employees or for your everybody that's, anybody that's related to you in your company? It's just really impossible to know about the ever thing. Nonetheless, it is there. And so I think one of the things that's really important is that you really should be, and you may not have this in your applications and in all of your documents when you're asking people if they're to work with you or whatever, is that you have to ask that question. Now, if you ask that question and they say no, I think you're okay. But if you don't ask the question, then you're not quite as, you probably should ask that question. Still, it's a very powerful, and it's saying, as it is, has anybody ever, and you're supposed to certify to this information.
Yeah. Now understand though, it's not a substitute to put this question on an employment application, because anyone who has ever been excluded, if they're still excluded, they will always say, nope, never have, because they know that they won't get the job. Okay. So
or they think that it's over.
You ought to have this as part of the application, and you should also screen before they walk into the organization. Okay. But you do want to at least have that in the in the application, because if you ever do have a problem, you want to be able to show OIG you're doing everything you can to kind of keep these people out. And even, let me tell you something, guys, even having this in the application and screening people before they walk in the door, you're going to have mistakes. You're going to have people that are excluded once they've come on board, and you're not going to know about it until, if you're doing it every month, hopefully within a couple of weeks. But that's all you can do. That's the most you can do. Next slide. Okay. Also, this is also in the provider agreement. You know, they say, you know, the provider understands it's their responsibility to ensure that it has disclosed. So once again, they're going through and they're making you sign all these things, saying, I know it's my responsibility. If anybody has ever been excluded, I know it's my responsibility to find out about it. And then you have to sign down at the bottom, you know. And now, wherever has been suspended or excluded from Medicare, Medicaid, or other federal health benefit programs. Next slide. And here is yet another provision. I mean, the Louisiana Medicaid Provider Agreement is just chock full of reminders that, I mean, even more than Texas. And I thought Texas had a lot, but you know, it's just full of it all the way through. They have a separate addendum. If it wasn't enough to have 5 other pages where you had to say that you hadn't done it, then they have an addendum here to also say you haven't done it. Okay, so, you know, once again, provider understands that if anyone has ever been employed by a corporation, business, or professional association that is now or ever has been suspended or excluded, it just goes on and on and on. Next slide. Okay, all right. So, Paul, I'm going to let you talk about these 2 cases, but before we kind of get there, I just want to point out that for the folks that take Medicaid in Louisiana, you have signed at least 7 times. I know check boxes are signed at least 7 times in the application. Yeah, I know I'm supposed to check this, and no, nobody has been excluded. That is really important, because if in fact you have made a misstatement, you know, that's a lie, and that in and of itself is a separate crime. You know, would Martha Stewart go to jail? It wasn't because she engaged in insider trading. It was because the government said she lied to the government. Okay, so it's so important that you understand what your obligations are, and that you are in fact screening to make sure that no one has been excluded. And there are a couple of really interesting cases, Paul, that I know you're really familiar with. Can you talk about these?
Yep. So, but one thing I'm also going to say is, remember, you have to re-enroll every 3 years, I believe, in Medicaid, and so you're re-signing all of those. Also, since now you're enrolling separately in the Part C and the Part C plans as a provider, since you're enrolling there, you are again affirming whatever your obligations are. Probably they say that you are consistent with your state obligations. So you're not just signing it once.
And plus, Paul, there's multiple Part C plans, right? I mean, you can have a dozen of them.
Everybody. And also and by the way, all the Medicaid, that's not one, it's not ubiquitous. It's not one single Medicaid managed care plan. All of those care plans have, you're signing up with them individually as well as with the state. That's the typical way. So anyway, you're signing your stuff that's crazy. Why do we do that? But that's another thing to talk about another day. So these are 2 cases. You know, these are cases that show that, you know, really these are just about the only 2 state Medicaid convictions that I've seen. There are maybe a couple more, but not very many. So the first one is the billing case that I was talking about, right? He was, the gentleman was an excluded doctor. He says, I know healthcare, I'll become a biller. The Medicaid fraud control unit, these are people that I worked with. They're very good in Louisiana, by the way. Not all Medicaid units are all that great. The MAFUCA, the fraud control unit in Louisiana was outstanding when I was there. We worked closely together, and they went after this guy, and he appealed it. He says, I have a right to do it. The Supreme Court said, no, that's a crime. If you were a biller, you are contributing to, if you've been excluded under these programs, he had been, it's a crime. The second one is really even more extraordinary. This was a doctor. He pled nolo contendere, so that's one of the issues we talked about earlier of Medicaid fraud, like 16 years earlier or 14 years earlier, 1992. I'm guessing he finally found out that So anyway, he's working for a doctor who's doing Medicaid. Supposedly, all they went after him for was for his services to be billed under that doctor's number while the doctor was in the hospital. That was it for like 6 days or something like that. He got 2 years. He got 2 years of home confinement, 5 years of hard labor suspended, but 2 years of home confinement for just those few days of having his services billed under Medicaid. There may have been a backstory to that. That may be a lot of it, but that's all they talked about in the opinion. Just a handful of days when the doctor was unavailable and his services were being billed under the doctor's number for Medicaid. And so that was a pretty serious matter. This is not taken lightly.
No, the state of Louisiana does not mess around.
And by the way, those were NOLO too, which is what we've talked about.
It's crazy. But this whole idea, I mean, on its face, he sounds like a pretty good guy. He's covering for this other doctor who was in the hospital for a few days, and they still went after him for something that happened 20 years ago. So
I have to think there was a backstory, but there was no
well,
no
I would hope so.
But it wasn't in the case. It wasn't in the opinion. So don't mess around.
Don't mess around. Next slide. Okay, you really, I'm not going to belabor this. Since you're participating in Medicare and Medicaid in the state of Louisiana, you are supposed to have an effective compliance plan in place. Screening is one of the 7 elements now, and it's something that you're supposed to be doing. Next slide. All right, so what can happen? And we're running out of time, unfortunately, so we're going to have to hurry through this. You can be held liable under civil monetary penalties. Remember, even if it's not a billing provider, if it's not like a doctor billing under his own number, it's a nurse or it's the receptionist that works in your office, okay? All of those claims associated with that person's employment are tainted. And for each one of those claims, you can be hit with a civil monetary penalty. At a bare minimum, okay, the government's going to go after all of those claims that were submitted during the period, and they're going to say that they constitute an overpayment. And I will tell you that under certain circumstances, the government has actually brought at least 2 False Claims Act cases based on the improper employment of someone who is excluded. So this is serious. The penalties out there are really, really serious. Next slide. If you find out about this, if you find out that you actually are employing someone who is excluded, they can't work there. You have to fire them, okay? And then that starts the clock when you find out about this, because if you don't turn over that money and do a voluntary disclosure, that turns into a False Claims Act violation under the Affordable Care Act. Next slide. We're running out of time. We can talk about the False Claims Act some other time, but the False Claims Act, of course, is the sort of Damocles. You can have significant penalties, anywhere from $15,000 to $23,000 or so per false claim plus treble damages. Next slide. This is something else we've already talked about this. When you fill out that application, you're saying no one is excluded, and if this is just, I guess this is signature number 8. Should put this at the other. Next slide. Okay. All right. If you find somebody who's excluded, what do you do? Well, you got to get rid of them, and you got to figure out how to resolve it, how to fix it, how to turn money over to the government, how to report it in a way that hopefully is going to keep your exposure at a minimum. Normally, we would do that with a voluntary self-disclosure. It's one of the few times that we recommend that you really take the voluntary self-disclosure program, OIG's self-disclosure program into account. But frankly, it's set up just for that. This is the best way to use that program as far as I'm concerned, because there's no other way to fix the problem. And if you don't fix it, then that overpayment ripens into a False Claims Act violation. Next slide. We'll just talk about that. Next slide. Okay. Paul, this is from exclusion screening. You want to just briefly talk about these three settlements?
Well, this is since we're pretty much out of time, but what they show is that, look, these are three relatively recent resolutions involving home health and home care services. And they're not, that's not a slap on the wrist. 146,000 for an aide, 158,000 for a CNA, 138,000 for a personal care assistant. I mean, and I've seen lots more. I've seen them for people who are just the receptionists and so on. I mean, the numbers are, and it shows the focus. If they find somebody that provides direct care, that's where they're going to go after that. They're not going to be easy. They're not going to say, oh well, they were just a CNA, or they were just providing personal care. They were just this, just that. There is no just in the OIG's mind when it comes to someone that's in the house or in the room and providing direct hands-on, potentially hands-on care or services. I think that's really the bottom line, and that's the impact for this audience, for the folk we're talking to.
Thank you. Yeah. Next slide. Okay, very quickly we'll talk about preclusion. We're going to make it quick because there's not much you can do about it anyway. What happened was, just as background, in 2018, CMS issued a final rule that essentially made it to where, in the future, Part C and Part D payers were going to, from then on, they were going to be handling their own credentialing, and they were going to pick up a lot of the slack because, these Part C and Part D players, I mean, they're quasi-private to begin with. They're private organizations that are administering their version of the managed care contract for beneficiaries. And one of the things that this new rule also required is they set up something called a preclusion list, because if CMS was going to kind of get out of the business of having to micromanage the Part C and Part D programs and credentialing, they said, well, you've got to have a separate list for people who have been kicked out, if you will, or identified as bad actors and can't participate in those programs as a provider. Next slide.
So they are essentially people who are, if they're already on the exclusion list, they don't go on the preclusion list because they're already on the list. These are people, basically, as I understand it, these are people who CMS would not allow, would not grant privileges into the Medicare program, and that they think that they shouldn't be granted privileges. They shouldn't be allowed to be providers in Part C or Part D. But they can't.
The weird thing about it, though, yes, everyone on the exclusion list should be on the preclusion list, but everyone on the preclusion list is not necessarily on the exclusion list.
They're not supposed to. If they're on the exclusion list, they don't need to be put on the preclusion list. Is kind of the way as basically what they're saying is, well, you have to screen those. This is like an additional list. If they've made it to the exclusion list, they should be taken off the preclusion list. These are folks that they wouldn't grant credential, wouldn't allow into Medicare. It's a crazy idea because you can't see it.
It's especially crazy because you can't check it. Next slide.
But the person should know that they're on it, and you have to ask them if they're on it.
That's the bad part. And these people that are on it, they consider it to be bad actors, and that's a term of art that CMS actually uses. These are folks that CMS says if they were to apply, we wouldn't let them.
Right. And maybe these are people that did apply and they wouldn't grant them. They wouldn't allow them to get a Medicare number, and so they want to let who knows, right? That would be interesting to look at. All right,
Next
people
slide.
are ready to go. Lunchtime.
Yeah.
Over.
Next slide. Okay, so there is a difference between the two programs. So, don't get those confused. You do have access to the exclusion list, the LEIE, and theoretically the states. You do not have access to the preclusion list. You're only going to hear about that from one of two parties. You would hear about it from the person who is supposed to tell you, hey, I've got a problem, or you might hear about it from Medicare Part C and Part D when they tell you that they're going to deny payment because you're employing someone who is on that list. Next slide. There are a couple of different broad categories of how you end up on the preclusion list. One is revocation based, and then the other, next slide. The other is really conduct and behavior based, and essentially the conduct and behavior is kind of the broadest one. If CMS determines that there is some underlying conduct that they think would have led or could have led to revocation if you were to participate in Medicare, then they can put you on the preclusion list, even if you never participated in Medicare Part A or Part B to begin with.
It's just a mystery how they would come up with those people. I just, unless they were denied privileges to Medicare, that would possibly be it. But other than that, how would they come up with these people?
I don't. Well, the only thing I can think of, I think that you're right. I think that maybe people apply, and I don't know. It's crazy. It really is it's very difficult. Next slide.
Scouring the lists of people who have license problems.
Yeah, that's not happening. Now, these individuals, once they, they're supposed to, this doesn't make any sense either because they, if someone is put on the preclusion list, they're supposed to get a letter that's sent to them, at their address in the PAYCO system. Well, none of your people, none of your nurses are going to be billing people, and they're probably not going to be, how are they going to get those letters? It is a mystery. Next slide. Okay, final remarks. Paul, you want to talk about this?
No, I mean, I think we've really talked about that. The risks are high, civil money penalties, and all that stuff. But really, the biggest risks are to yourself, right? In that, you've got someone that may cause problems for you and to your patients. And that's really the bottom line from as I can see. You got to screen, do it. It's not expensive, by the way. It's really, as I tell every physician practice, it's never, ever as much as it costs them for the water in their waiting rooms. You guys may not have a waiting room, so I'd have to figure out a different one for you. But it's not expensive.
But do yourself a favor, screen your folks. Make sure that no one has been excluded from participation because it's a very expensive situation if in fact they have been. And as always, if you have any questions, you can call me or you can call Paul. I believe our phone numbers are on the very first slide. And we appreciate the opportunity to make this presentation. Thank you very much, Dr. Hebert.
Paul and Robert, thank you so very much. We appreciate the partnership with Lyles Parker and look forward to our next event. Have a good day.
Thank you.
Thank you so much to our presenters, Robert and Paul, for the information, and thank you to our attendees and Dr. Hebert for joining us today. And I'll be sending a copy of the PowerPoint slides tomorrow. And if you have any further questions, reach out to them. We do have one question if you guys want to go ahead, or do you guys just want me to email you?
Sure.
So it says, I have an applicant who is listed in the OIG Exclusion List. On the IDPH website, look up. This nurse's license is on probation, but active and renewed repetitively every year. And this nurse is working with the IDPH hearing probation status. And may I know if we can hire this nurse?
If they're on the LEIE, she's not eligible. Now, it could be that her time is up and she may be eligible to try to get off the list. But, the fact that she's got a good license, and even if she's on, none of that matters. If she's on the LEIE, she's not currently eligible to work for you.
Okay. Yeah, that's the only question that we had. Other than that, hope to see you all next webinar. Thank you, Mr. Robert and Paul.
Yeah, great. I'll just mention, if I may, Gio, that the recordings of these presentations are available at Lyles Parker's YouTube channel. I know a lot of people have colleagues that perhaps don't get a chance to attend. Just know that this valuable information is present there. Thank you.
Thank you.